Hi, class, and welcome to part C of chapter 21. As you remember, there's three parts to this chapter. Part A, I didn't touch over because it was just a review of the anatomy of the respiratory system. And then I made a part B lecture, and then this is the part C lecture. So we're continuing our talk about the respiratory system, and now we're going to get into how the respiratory gases are transported in the blood. So we'll talk about oxygen transport, and then we'll talk about carbon dioxide transport. First of all, molecular oxygen is carried in the blood in two ways. 1.5% is dissolved in the plasma, and over 98% is loosely bound to each iron of the hemoglobin protein in red blood cells. So we'll talk a little bit about how oxygen and hemoglobin are associated or connected together. Each hemoglobin molecule is composed of 4 polypeptide chains, each with an iron-containing heme group. And this iron-containing heme group is what attaches to the oxygen molecule. So each hemoglobin can transport 4 oxygen molecules. We call oxyhemoglobin the hemoglobin-oxygen combination, and reduced hemoglobin or deoxyhemoglobin is when hemoglobin has released its oxygen. So hemoglobin and oxygen gets connect together to what we call oxyhemoglobin, and then it's released in the tissues when it dissociates. So oxyhemoglobin takes oxygen to the tissues. Deoxyhemoglobin picks up oxygen from the lungs. The loading and unloading of oxygen are facilitated by the change in shape of hemoglobin. So as oxygen binds to the hemoglobin will change shape, increasing its affinity for oxygen. And as oxygen is released, the hemoglobin shape changes again, causing a decrease in affinity for oxygen. If we say hemoglobin is fully saturated, that just means that all 4 heme groups in the hemoglobin are carrying the oxygen. And partially saturated means when only 1 or 3 heme groups is carrying the oxygen. The rate of loading and unloading of oxygen to the tissues is regulated to ensure that there's adequate oxygen delivery to all the cells. So there's several factors that influence hemoglobin saturation: the partial pressure of oxygen, and then other factors like your temperature, your blood pH, the partial pressure of carbon dioxide, and also the concentration of BPG, which is what we'll talk about. The partial pressure of oxygen heavily influences the binding and release of oxygen with the hemoglobin, and the percent of hemoglobin saturation can be plotted against the partial pressure of oxygen concentrations. The resulting graph is not linear, but S-shaped, and we refer to this as the oxygen hemoglobin dissociation curve, which was what we'll talk about. So this is a look at the oxygen hemoglobin dissociation curve. And what it basically is showing, this axis tells you how much oxygen is bound to hemoglobin. So for example, at 100%, each hemoglobin molecule has 4 bound oxygen molecules. In the lungs, where the partial pressure of oxygen is high, hemoglobin is almost always fully saturated with oxygen. This circle point in the tissues at other organs, the partial pressure of oxygen is low, and hemoglobin is less saturated. And this axis tells you the relative amount of the partial pressure of oxygen dissolved in the fluids surrounding the hemoglobin itself. So that's the oxygen dissociation curve, and several factors will move the dissociation curve to the right or the left to either increase oxygen offloading from hemoglobin or decrease that. So for example, in your arterial blood, the partial pressure of oxygen is very high, about 100 millimeters of mercury, and contains 20 milliliters of oxygen per 100 milliliters of blood. So hemoglobin will be about 98% saturated in arterial blood. Further increases in the partial pressure of oxygen, such as deep breathing, will produce minimal increases in oxygen binding. And in venous blood, in your veins, the partial pressure of oxygen is lower, so hemoglobin will be less saturated. And the venous reserve refers to the oxygen remaining in your venous blood that can still be used. So this is a look at different factors in the oxygen hemoglobin dissociation curve. So there's 2 line graphs here. The second graph shows, so The first graph shows, and I'm going to make it a little bigger so we can see this. At high partial pressures of oxygen, large changes in partial pressures of oxygen cause only a small change in hemoglobin saturation. So notice the curve is relatively flat here. Hemoglobin's properties produce a safety margin that ensure that hemoglobin is almost always fully saturated, even when with a substantial partial pressure and oxygen decrease. So as a result, the hemoglobin remains saturated even at high altitude or with lung disease. For example, in the tissues at low pressures of oxygen, large changes in oxygen cause a large change in hemoglobin saturation. So tissues other than the lungs have a low partial pressure of oxygen because they consume oxygen. And notice that the curve here is relatively steep at low partial pressures of oxygen, and hemoglobin's properties ensure that oxygen is delivered where it is most needed. When tissues need more, they get more, such as your muscles during exercise. Other influences of other factors on hemoglobin saturation, so increases in temperature, H plus, which refers to the pH, partial pressures of carbon dioxide, or BPG can modify the structure of hemoglobin. They can all result in a decrease of hemoglobin's affinity for oxygen. So this occurs in your capillaries. And what this does, so when your temperature increases, for example, this enhances oxygen unloading. So what this means is that it causes a shift in the oxygen hemoglobin dissociation curve to the right. So anything that causes the oxygen dissociation curve to shift to the right means that it enhances oxygen unloading. So this usually happens in terms of if temperature increases, acidity increases. If someone is doing a lot of, for example, exercise, it will enhance oxygen unloading so the tissues can get more oxygen. Decreases in these factors will shift the curve to the left, so it'll decrease oxygen unloading from the blood or just increase the affinity of the hemoglobin for the oxygen. So here's the effect of temperature and blood pH on oxygen dissociation curve. So normal body temperature is about 40, normal body temperature is about 38. So if body temperature increases up to 43, it shifts the curve to the right, which means that it increases oxygen delivery to tissues. And if body temperature decreases to 20 or 10 degrees Celsius, it'll hold on to the oxygen more tightly. So it'll shift it to the left. Same thing happens. Here's the effect of temperature. This is a look at the partial pressure. So normal arterial carbon dioxide and normal pH is about 7.4. So that's showing the middle curve. Increased carbon dioxide or a decreased pH level or increased acidity moves the curve to the right, and decreased carbon dioxide or an increase in pH will move the curve to the left. BPG is produced by your red blood cells during glycolysis, and BPG levels will rise when oxygen levels are low. So this just means as your cells metabolize glucose, they use oxygen, causing an increase in the pressure of carbon dioxide and H in the capillary blood, declining blood pH or acidosis, and increased levels of carbon dioxide cause the hemoglobin oxygen bond to weaken. And this is referred to as the Bohr effect. So oxygen unloading occurs where it's needed the most. Heat production in active tissues directly and indirectly decreases hemoglobin affinity for oxygen, and this just allows increased oxygen unloading to the active tissues. Now we'll talk about the carbon dioxide transport. Carbon dioxide is transported in the blood in three forms: in dissolved plasma and then chemically bound to hemoglobin. Chemically bound to hemoglobin, we refer to it as carb-aminohemoglobin. As a bicarbonate ion in the plasma, so most of your carbon dioxide is actually transported in the plasma as what we call bicarbonate ion, about 70%. And the formation of bicarbonate involves carbon dioxide combining with water to form what we call carbonic acid, which quickly dissolves into bicarbonate ion and hydrogen ion. So again, most of your carbon dioxide is transported in the blood as this bicarbonate ion. It occurs primarily in red blood cells where the enzyme carbonic anhydrase will reversibly and rapidly catalyze this reaction. And in your capillaries, the bicarbonate ion will be created and it quickly diffuses from the red blood cells into the plasma. So, this outrush of bicarbonate ion from your red blood cells will be balanced as the chloride ion moves into the red blood cells. And this is referred to as the chloride shift. So, this just shows how carbon dioxide is transported into your red blood cells, and then it undergoes this reaction that forms bicarbonate ion, which then leaves your red blood cells and travels into the plasma. So, again, about 70% of your carbon dioxide is transported in the body as this bicarbonate ion in the blood plasma. And the chloride shift just refers to the action of the bicarbonate ion leaving the red blood cells, the chloride ion entering the red blood cells, and that's referred to as the chloride shift. In the pulmonary capillaries, the processes occur in reverse. So the bicarbonate ion moves back into the red blood cells, the chloride ion moves out into the plasma. Then the bicarbonate ion will bind with hydrogen to form this H2CO3. And then the H2CO3 is split to form carbon dioxide, which will diffuse into the alveoli of your lungs and get exhaled. So we have this kind of, again, reversible reaction that's occurring with your, so this is the reverse of the reaction, showing how the bicarbonate ion then forms bicarbonate anhydrase and eventually CO2, which diffuses into your lungs to be exhaled. The Haldane effect refers to the amount of carbon dioxide transported is affected by the partial pressure of oxygen. The lower your partial pressure of oxygen, the lower hemoglobin saturation, the more carbon dioxide can be carried in the blood. Reduced hemoglobin buffers this hydrogen ion concentration to form the carb amino hemoglobin more easily. So this process just encourages the carbon dioxide exchange at the tissues and the lungs. So at the tissues, as more carbon dioxide enters the blood, more oxygen will dissociate from hemoglobin. As hemoglobin oxygen releases oxygen, it more readily forms bond with carbon dioxide. So again, what's happening here is the hemoglobin is carrying oxygen to your tissues and picking up carbon dioxide to be transported back to the lungs. This carbonic bicarbonate buffer system helps the blood to resist changes in pH. So it's very important that your blood always maintains a consistent pH of about 7.4. If hydrogen ions concentrations rise, excess hydrogen ions will be removed by combining with this bicarbonate ion to form this, which dissociates into carbon dioxide and water. If the hydrogen ion concentration begins to drop, it will release excess. The bicarbonate ion will be considered the alkaline reserve of the carbonic acid bicarbonate buffer system. So what this again is just sharing, and this is what your recent workshop of gas exchange goes over. Changes in your respiratory rate and depth will affect the blood pH. So slow and shallow breathing cause an increase in carbon dioxide because you're not exhaling a lot of CO2. So this will cause an increase in CO2 in the blood, resulting in a drop in pH. Whereas if you're rapidly breathing, this will cause a decrease in carbon dioxide because you're breathing out excess CO2. And this will result in a rise in pH. So these changes in respiratory rate are really important in affecting the blood pH levels because the amount of CO2 in the body directly affects the pH levels of the blood. Changing in the ventilation can help adjust the pH when disturbances are caused by a metabolic factor, for example, and breathing will play a major role in the acid-base balance in the body. And again, try to go to the workshop that talks about gas exchange because it kind of goes over this topic a little more in depth. Hypoxia refers to inadequate oxygen delivery to tissues. It can result in cyanosis and is classified by a specific cause. So anemic hypoxia is when there's too few red blood cells or abnormal or too little hemoglobin. Ischemic hypoxia refers to impaired or blocked blood circulation. Histotoxic hypoxia refers to when cells are unable to use oxygen, as in metabolic poisons like cyanide. Hypoxemic hypoxia refers to abnormal ventilation, pulmonary disease, or low levels of oxygen in the air. And carbon monoxide poisoning is especially what happens during fire. And hemoglobin has a 200 times greater affinity for carbon monoxide than oxygen. So the victims have headaches, can become flushed because basically their hemoglobin is binding to carbon monoxide and not oxygen. This is a great video on gas exchange that I would encourage you guys to watch. Control of respiration. So your respiratory rhythms are regulated by your higher brain centers, chemoreceptors, and other reflexes. You have different medullary receptors in the brain, the ventral and dorsal respiratory group. I won't ask you guys too many questions on the neural mechanisms, but I do want you to understand what the breathing does and how it either increases or decreases these acid-base imbalances. The ventral respiratory group is one of the groups in the neurons that extends from the spinal cord to the pons medulla junction. These are more neural mechanisms that help to control normal respiratory rate rhythm. I won't ask you guys too many specifics on these neural mechanisms that control breathing. I just more want you guys to know how your breathing changes if you have a more acidic blood level or a more basic blood level. The respiratory centers are infected by chemical factors, higher brain centers, pulmonary irritant reflexes, or an inflation reflex. The most important of all the factors affecting depth and rate of inspiration are the chemical factors. So any change in the partial pressure of carbon dioxide, oxygen, or pH are the most important. So that's what I want you guys to know. The influence of carbon dioxide is the most potent and most closely controlled. So if your blood levels of carbon dioxide rise, carbon dioxide will accumulate in the brain and joins with water to become carbonic acid. This will dissociate, releasing hydrogen ions, causing a drop in pH or an increase in acidity. The increase in acidity tells your brain to basically tell your respiratory systems to increase depth and rate of breathing to try to lower the blood CO2 levels so the pH can rise back to normal levels. If blood levels of carbon dioxide decrease, the respiration comes shallow. This is apnea, where the breathing sometimes stop. This can occur when carbon dioxide levels drop abnormally low. Swimmers sometimes voluntarily hyperventilate to enable them to hold their breath longer, which will cause a drop in your partial pressure of carbon dioxide, causing a delay in respiration as carbon dioxide levels are increased, needed to build back up. So this is what you should have a good understanding for how the changes in partial pressures of carbon dioxide can help regulate breathing by a negative feedback mechanism. Hyperventilation means you are breathing more, so the increased depth and rate of breathing is exceeding the body's need to remove carbon dioxide. This may be caused by an anxiety attack, which could lead to a decreased blood carbon dioxide level because you're breathing out excess CO2. This can result in dizziness, fainting. The treatment is to breathe in a paper bag to try to increase carbon dioxide levels back in the body. Influence of oxygen is not as common on factors influencing breathing rate and depth. And this is the location and innervation of the peripheral chemoreceptors in the carotid and aortic bodies. pH can modify the respiratory rate and rhythm, even if carbon dioxide levels are normal. And this is mediated by peripheral chemoreceptors. Decreased pH may reflect carbon dioxide retention, accumulation of lactic acid, or excess ketone bodies. The respiratory system controls the attempt to raise pH by increasing respiratory rate and depth. So this is just a summary of chemical factors, which you can review on your own. It's a great summary for you for that. More influence of higher brain receptors. Again, I won't ask you specific questions about how higher brain receptors are involved. I more just want you to understand how carbon dioxide in the body adjusts respiratory rate. During exercise, adjustments are geared to both intensity and duration. Hypernemia is the increased ventilation in response to metabolic needs. Ventilation will increase abruptly, increase gradually, and then reach a steady state. When exercise stops, there's a small abrupt decline in ventilation following by a gradual decrease. Abrupt increase in ventilation that occurs as exercise begins involves these three neural factors, which I'll let you read through on your own. Ventilation will then decline suddenly as exercise ends because the three neural factors will be shut off. Exercise will lead to anaerobic respiration and the formation of lactic acid. Because there's a lack of oxygen in the muscles, it's not from poor respiratory function, but rather from sufficient cardiac output or skeletal muscle inability to increase oxygen intake. High altitude, quick travel to altitudes above 8,000 feet may trigger symptoms of acute mountain sickness, where the atmospheric pressure and oxygen levels are lower at high elevations. So there can be headaches, shortness of breath, nausea, and dizziness. In some severe cases, it can be lethal cerebral and pulmonary edema may occur. High altitude, we need to be mindful to try to acclimate where the respiratory and hematopoietic adjustments are made with long-term moves to high altitude. So your chemoreceptors will become more responsive to partial pressures of carbon dioxide when oxygen levels decline. Substantial decline in oxygen directly stimulates peripheral chemoreceptors, which will result in increase in minute ventilation that stabilizes in a few days to 2 to 3 liters per minute higher than at sea level. High altitude conditions always result in lower than normal hemoglobin saturation levels. So due to basically less oxygen available, the decline in blood oxygen will stimulate your kidneys to accelerate the production of erythropoietin to try to increase your red blood cell numbers slowly to provide long-term compensation. So that is why athletes will often train at higher altitudes, because their bodies will adjust, their kidneys will stimulate your erythropoietin levels, which will increase red blood cell numbers. And if athletes have more red blood cells, they'll have more oxygen delivery to your tissues. We'll end the chapter then talking a little bit about lung diseases. Chronic obstructive pulmonary disease, you'll hear often abbreviated as COPD, is exemplified by chronic emphysema and chronic bronchitis. The key feature is an irreversible decrease in the ability to force air out of the lungs. Other common features of COPD is usually a history of smoking, dyspnea, which is labored breathing, coughing, frequent pulmonary infections. Most patients develop hypoventilation, which is accompanied by respiratory acidosis, hypoxemia. Emphysema is a permanent enlargement of your alveoli and the destruction of alveolar walls, resulting in decreased lung elasticity, with the three consequences. Your accessory muscles are necessary for breathing, leading to exhaustion. There's trapped air causing hyperinflation, which flattens your diaphragm, causes an expanded chest, both of which reduce ventilation efficiency. And then your damaged pulmonary capillaries lead to an enlarged right ventricle of the heart. Hereditary factors for disease can include the alpha-1 antitrypsin deficiency. Chronic bronchitis is when you inhale irritants causing chronic excessive mucus. The mucosae of the lower respiratory passageways become inflamed, fibrosed with scar tissue. This can result in an obstructive airway that impairs lung ventilation and gas exchange. Symptoms include frequent pulmonary infections. The risk factors include smoking and environmental pollutants. COPD symptoms and treatment. The strength of the patient's innate respiratory drive is the reason behind different symptoms that are seen. Pink puffers is when the patient usually is very thin because they burn large amounts of energy when they're breathing. Their near normal blood gases are maintained, so the skin color is normal. Blue bloaters is when the patient is usually stocky and their cyanosis is due to hypoxia, so the skin takes on a bluish hue. And the treatment is usually a bronchodilator, corticosteroids, oxygen, and sometimes lung volume to reduce lung volume reduction surgery, and oxygen must be administered carefully. So this is just a look at the pathogenesis of COPD, tobacco smoke, air pollution, sometimes hereditary with the alpha-1 antitrypsin deficiency, and then what it will do, either breakdown of elastin causing emphysema or continual bronchial irritation causing chronic bronchitis, and then what happens to the airways and what happens to breathing. So again, smoking is one of the big factors in this. Asthma is sometimes classified as COPD, but episodes are more acute, not chronic, with usually symptom-free periods. It's characterized by coughing, dyspnea, wheezing, and chest tightness. Active inflammation of airways precedes bronchospasms. Airway inflammation is usually an immune response caused by the release of interleukins, the production of immunoglobulin E, and recruitment of inflammatory cells. The airways are usually thickened with inflammatory to try to magnify the effects of bronchospasms. Tuberculosis then is an infectious disease caused by a bacteria. The symptoms are fever, night sweats, weight loss, cough, coughing. The treatment is usually a 12-month course of antibiotics. Lung cancer then is the leading cause of cancer deaths in North America. 90% of all cases are the result of smoking. There's 3 common types: adenocarcinoma, which originates in the peripheral lung areas. Squamous cell carcinoma arises in bronchial epithelium, and then small cell carcinoma contains lymphocyte-like cells that originate in the primary bronchi and will subsequently metastasize. Treatment for lung cancer is early detection. If metastasis has not occurred, to remove the diseased lung tissue, and if metastasis has occurred, to try to radiate and chemotherapy to kill off the cancer cells. There are several new therapies. Sleep apnea then is a common disorder characterized by temporary cessation of breathing during sleep. The person usually is not aware of the problem. Usually their significant other is, because they notice them not breathing when they're sleeping. It can lead to excessive daytime sleepiness due to waking up several times each night. Obstructive sleep apnea is the most common type, caused by the collapse of the upper airway, where the pharynx muscles will usually relax during sleep and then sag, causing an obstruction. Central sleep apnea is caused by the reduced drive from the respiratory centers of the brainstem. Consequences of disrupted sleep usually are susceptibility to accidents, increase in chronic illnesses like hypertension, heart disease, stroke, and diabetes. And obstructive sleep apnea can be treated using a CPAP, a continuous positive airway pressure device, which keeps the airways open. That's the end of this chapter. Chapter 22 gets us into digestive system, and I hope you guys are all doing well.